think there are two major developments in the treatment of adjuvant melanoma. One is the data showing that anti-PD-1, both nivolumab and pembrolizumab, improve progression-free survival. The data are really quite remarkable. The data that was presented here at ASCO with longer follow-up suggests 63% recurrence-free survival at 2 years compared to 50% for nivolumab versus ipilimumab, for example. So that's very exciting data, and that suggests that we can treat our patients in the adjuvant setting with a drug with not a lot of toxicity and reduce their rate of recurrence. We still don't have survival data yet, but my guess is that over time we will see a survival advantage. The only key question is whether it's better to give the therapy in the adjuvant setting versus waiting until they recur and give it at the time of recurrence. That's still a major question in the field. Second major advance was really the recent data showing that for patients who have BRAF mutations, that a combination of dabrafenib and trametinib improved progression-free survival, and there was a trend towards improved survival in that study also. So for patients who have BRAF mutations, you have two options, either nivolumab or dabrafenib trametinib. Another major question for us is if someone gets these therapies in the adjuvant setting and then they progress, what are we going to treat them with at the time of first metastatic disease? So that still remains unsettled. Certainly for anti-PD-1, probably some patients would respond again to anti-PD-1. Maybe they'll get anti-PD-1 plus ipilimumab. If you've progressed off a BRAF MEK inhibitor, certainly you're still eligible to get an immune therapy. But nevertheless, it provides us options that we never had before for drugs that are overall fairly well tolerated. I think a lot of it is bias. I don't know. They have to be compared head to head in order to know for sure which one is if either one is superior and whether some patients group would benefit more from one type of therapy versus another. But I generally tend to use anti-PD-1 in most of my patients, and I save the BRAF MEK inhibitors for relapse. Dr. Weber today actually mentioned that, which I think is very reasonable, for patients who are on anti-PD-1 and develop a local recurrence, they could get that resected and then go on BRAF MEK inhibitors, assuming that, of course, that they have a BRAF mutation. Certainly the further along in stage they are, so the closer, for 4A, 3Cs, 3Bs, the higher the stage, the more likely I am to use an immune therapy. I think when we looked at the BRAF MEK data and looked at it by stage, the ones that had the most benefit were the earlier stage patients. I think that's where I would come down, but really for most patients would probably offer nivolumab or pembrolizumab first. My guess is that if most high-risk patients receive adjuvant therapy, particularly the immune therapies, those are potentially curative, which means that the number of patients coming to metastatic disease will drop. We'll see fewer cases of metastatic melanoma. As you know, most patients with melanoma present with primaries, not with metastatic disease. So if we catch them at that time, either with or without regional node dissection, sentinel node biopsies, and then give them adjuvant therapy, we'll probably cure them in that setting, and then we won't see them at the time of metastatic disease. On the other hand, at the time of metastatic disease, we'll have at least reduced the number of options that we have for treatment of those patients if they do relapse or progress. If you've had a BRAF MEK inhibitor, here's the one thing, though, that we need to consider. For these agents, for example, if you, in the advanced disease setting, if you give these agents and you respond, you stop the therapy, and they progress at some point in the future, there is a reasonable chance they'll respond again to the same agents. So even if you've had the BRAF MEK inhibitor in the adjuvant setting, if there's been a period, a lag period between the time you stopped and the time that you progress, you may be able to use the BRAF MEK inhibitors again. The same thing is true for nivolumab. If you've had nivolumab, you've stopped it, and there's a period of time before the disease progresses, you could go back to the nivolumab again, or anti-PD-1, and probably get a second response. However, maybe those responses won't be as long or as durable. For patients of mine that have had anti-PD-1 in the adjuvant setting and then progressed, my guess is a standard of care, the first treatment that I would offer them would be ipilimumab and nivolumab. But hopefully we'll find other effective therapies with all these phase 2 trials that are going on. Maybe we'll have something else that's effective that we'll be offering in the frontline setting. It'll also mean that a lot more patients in the frontline setting will go back on clinical trials. Right now, a lot of those patients are doing so well with ipilimumab, nivolumab, or nivolumab alone, or pembrolizumab alone, or BRAF/MEK inhibitors alone, that a lot of those patients in the frontline setting really are not going on to clinical trials. So the standard of care for the combination of ipilimumab and nivolumab is to give 3 mg per kg of ipilimumab and 1 mg per kg of nivolumab. It's possible that the reverse ratio would be less toxic and equally effective, and there's been a randomized trial that I think is fully accrued. So we're waiting for those results. If it turns out that it's just as effective and less toxic, then we'll be using a modified dose ratio. What we haven't done in melanoma is what they've done in lung cancer, which is only give the ipilimumab every 6 weeks or every 12 weeks, which presumably would even be less toxic. But I think we would want another trial before we do that, because the regimen that we have now is really very effective. I mean, when you think that pembrolizumab or nivolumab alone at 5 years probably will give you a 40 to 45% survival, and with the addition of ipilimumab, you could get probably above 45 to 50%. You're going to have some increment there with a combination. I don't think we want to mess around too much with dose and schedule for the possibility that we might lose some efficacy for adjuvant therapy. I think that it's going to be one of the anti-PD-1s, either pembrolizumab or nivolumab. Nivolumab is currently approved. I think pembrolizumab not yet, but probably will be soon. So single-agent anti-PD-1 will be the standard adjuvant therapy for most patients, particularly patients who are BRAF wild type. For patients who have BRAF mutations, you have the choice of doing the BRAF/MEK inhibitor or one of the anti-PD-1s. So that will certainly be the standard of care. Right at the moment, there's no compelling adjuvant trial. The combination of ipilimumab and nivolumab was looked at a modified dose and schedule, but that trial already completed accrual. We're waiting for those results. We've discussed the real concern that's out there in the community that these drugs may work just as well when you give them at the time of relapse. So when you're giving these drugs in the adjuvant setting, you're treating a lot of patients who probably would not need to be treated, right? And you're subjecting them to potential toxicity. So if, in fact, treating at the time of metastatic disease, you have the same survival as treating in the adjuvant setting, then I think that adjuvant therapy is not the right thing to do for patients. You wait until they develop metastatic disease, so you save a lot of people from toxicity and the cost of unnecessary treatment. And that question remains unanswered. The EORTC trial that randomized patients to pembrolizumab versus placebo requires, at the time of metastatic disease in the placebo arm, to receive pembrolizumab. So we hopefully at some point in the future will have the answer as to whether it's better to treat early or wait until the time of metastatic disease. Well, in patients who haven't had adjuvant therapy, you can do 3 things with patients. Of course, there are variations depending on the individual patient, but if you have a BRAF mutation, you can either give a BRAF plus a MEK inhibitor. And there are 2 choices now, but there will be a 3rd choice, encorafenib and the associated MEK inhibitor. The data looked very good, so you have 3 choices for treatment of BRAF mutant patients. And actually the data that was presented today with the encorafenib plus the MEK inhibitor suggested maybe slightly increased activity with maybe better overall toxicity. So when those drugs become approved, that's really a viable option for those patients. And then you have either pembrolizumab or nivolumab, both are anti-PD-1 agents, or the combination of anti-PD-1, usually nivolumab, in combination with ipilimumab. And even there, you might have the option of 2 different dose schedules. So that's basically what's available today. But with that toolkit of agents, patients do exceedingly well. Survivals are going to be in the 45 to 50% range at 5 years. So that's an amazing advance. But what we really need to do now is figure out how to get the other 50% to that plateau. Well, there are hundreds, maybe thousands of different combinations that are being looked at. I think one thing that's easy to talk about right away are the adoptive cell therapies. So there are a number of people that are looking at that. at the time of relapse, and companies that are developing tumor-infiltrating lymphocytes, which are being developed for ex vivo culture and then adoptive cell transfer. And that might take care of a small portion of those patients. We really don't understand all the mechanisms of resistance, but you could think about going after metabolic issues like hypoxia. You could think about other checkpoint inhibitors like TIM3 and LAG3, and there's been data presented, for example, that there's a little bit of activity with the LAG3 agent and resistant agent in combination with anti-PD-1. You could look at co-stimulatory agents. So far, those haven't been overly active, but we need to wait. There, the cytokine data, so combinations like the Nectar-214 drug, the pegylated IL-10, there are other cytokines that are coming in combination with anti-PD-1. I think I could go on and on. There's just an enormous number of combinations. At our institution, Dr. Kluger and Dr. Weiss are about to lead a clinical trial combining a CSF1 receptor antibody together with a CD40 agonist. The CD40 agonist comes from Apexagen, and the CSF1 receptor antibody comes from Bristol Myers. And based on preclinical data, it was done by one of our scientists, Dr. Susan Keck, it had very interesting activity, that combination, in the mouse melanoma, spontaneous melanoma model. So we're going to do a phase 1, look at that combination. It has very interesting effects on tumor-associated macrophages, and then combine those two drugs with nivolumab. So that's an example of the many things that are out there that you could possibly combine to improve the activity of, or to achieve activity in the resistant setting. Oh, unquestionably we're curing, yeah. No, there's no question we've cured patients with melanoma. I think a very significant proportion of those people that are alive at 5 years are cured of their disease. Well, the IDO inhibitor is based on is real biology. The preclinical data are solid. This is a real mechanism of T-cell dysfunction in the tumor microenvironment. So giving an IDO inhibitor makes sense. And obviously when you give an agent like anti-PD-1 or other immune therapies and you activate a T-cell response, when those T-cells start making interferon gamma, they upregulate IDO, and that IDO then inhibits T-cell effector function. It causes an increase in Tregs. So there are a lot of things that IDO does that are bad. And so inhibition should work, at least in some subset of patients. The phase 2 data that was generated for epacadostat together with either nivolumab or pembrolizumab showed higher response rates and higher progression-free survival rates than we would have expected. And so I think we were all very excited about the data. And I think the phase 3 trial that showed no effect was a real surprise. However, it tells us two things. It tells us several things. One is anti-PD-1 is a great drug. So when you add to anti-PD-1, you have to have a huge signal in order to see something in phase 3. And today we saw long-term data for anti-PD-1 for pembrolizumab with amazing 4-year survival data. So it's a really great drug, and we're going to have to see a big signal. And maybe melanoma is not the right tumor for adding IDO. The second thing that we've learned is that when we do phase 2 trials, phase 2 trials are not that reliable, but that's not new news. We've known that since I've been in the business of drug development. So running a big phase 3 study off a 40 or patient phase 2 or 50 patient phase 2 trial is probably not a good idea unless you see a huge signal. And not only do you have to see a huge signal, but you have to understand the patients that went on that phase 2 trial, right? Because depending on patient selection, you have more PD-L1 positive patients, more patients with normal LDH. You might see a much better result than you would have expected, which makes it look like your combination is better. And the third thing we have to know is whether we've actually hit the target, right? Did that dose and schedule of the epacadostat really inhibit IDO to the degree that's necessary in order to get the biological effect? There are other IDO agents that may be different, and there are other IDO agents, in fact, that are different. The New Link genetics agent works by a slightly different mechanism, and there are other diseases. So even if it's not a win in melanoma, it still may be worth pursuing this, at least in some limited way in other diseases, to be absolutely sure that it doesn't have a role. I'm not convinced yet that it doesn't have a role. If the preclinical data weren't strong, I would say, well, this isn't worth pursuing, but it's real biology. The preclinical data are real, and so I don't think every tumor is going to respond the same way. We already know that that's the case. So, and that's one of the problems with development of immunotherapy. It's very similar to the old days of developing chemotherapy, when we would know that a drug is active in preclinical models, but it was empiric which tumor it would show activity in the clinic. We would do a phase 1 trial, and then we would do phase 2 trials in 20 different diseases, and maybe one of those two would be active, but we wouldn't know which one would be active ahead of time. So in immune therapy, we don't have great biomarkers, and so we're left with some empiric testing. So if you really believe in the biology, you probably ought to go beyond that one, phase 3 failure and continue to explore, at least in some limited way, in other tumors. That's going to be true, I think, for more than just the IDO agent. And let me just say one more thing, that we shouldn't give up on combinations, right? Because we were very excited about the IDO combinations, not so excited about chemotherapy. But look what chemotherapy, Pembro, has done in lung cancer, right? That's a remarkably positive result. So some combinations will win and some won't. Melanoma is probably, of the tumors out there, one of the most likely to respond to immune therapies. So when we had not very good agents, everything was tested in melanoma and kidney cancer first, with the assumption that things wouldn't work in other diseases. But I don't think melanoma is the bellwether anymore. First of all, because the diseases are different, they have different biologies. And the fact of the matter is that melanoma is a relatively small disease compared to lung cancer, colon cancer, breast cancer, prostate cancer, small cell lung cancer. So I think what we're seeing now is a shift by industry. Now that they know that these immune therapies will work in other tumors, there's going to be a greater focus, as you might expect, in developing those drugs in other tumors. And so I think the days when things are going to be developed in melanoma first or in kidney cancer first are long gone. Well, let's start with TLR9 injections. There are several trials out there, and the results seem to be surprisingly good, including activity in patients who are said to be resistant to anti-PD-1 treatment. I was never a strong believer in this idea that one could inject a single tumor and get enough immune activation that you would see systemic response. But data are data, and I think that if you put everything together, the TLR9 agonist, but also together with the preliminary data with TVEC, which is also another intratumoral injection, I think the data merits phase 3 testing. So it's as positive, with all the caveats we talked about earlier about phase 2 trials. It's about as interesting a data set as one could get, and I think it should be tested in a randomized study. I wouldn't, though, conclude on the basis of the data that's there yet that it's going to win. Sometimes melanoma is an unusual disease, and we see some unusual things, and so even a low response rate in a refractory disease may not translate into an overall effect in a big randomized phase 3 trial in the upfront setting. But we'll see. It should be tested. For LAG-3, there is activity in a few patients with resistant disease. It's a small number. It's approximately an 11% overall response rate, and in the ones that were LAG-3 positive, it was 18%. So there's a little bit of activity. I think the data we saw for the Novartis LAG-3 data today, not in melanoma, but just across all tumors, wasn't overall terribly compelling. But I think LAG-3 is a complicated story. There's more biology there, and I think as that biology is dissected, we may learn how to use it better, may even come up with better agents. So I'd say just to stay tuned for that one. And for the Nectar-214, I'm a big believer in cytokines. I think cytokines are an important component of what T cells need in the tumor microenvironment. I'm not sure that there's enough IL-2 there in some patients. The Nectar data so far is interesting. I think with further follow-up, the response rates have drifted down to a level that's close to what one might expect with anti-PD-1 alone, or a little bit better than what one might expect with anti-PD-1 alone. But again, this is an agent for which the preclinical data is very compelling in combination with anti-PD-1, and it merits a randomized study to see if it's better. It may be that melanoma is not the right tumor. It may be that the right tumor for Nectar-214 is lung cancer or bladder cancer. But I still think randomized trials are certainly should be done to see whether it does have an effect. And there are other cytokines out there that look very interesting, like the pegylated IL-10. It's hard to know. It's really hard to know what the optimal trial designs are to detect enough activity to move on beyond to a phase 3 study. It certainly helps to know that you have activity in the resistant refractory setting. So if you truly have somebody that's resistant or refractory to anti-PD-1 or anti-PD-1 in combination with anti-CTLA-4, and you see activity of a combination in that group of patients, you have a real signal. And maybe those are the agents that should have highest priority for moving forward. And when I say resistant or refractory, what I really mean is someone who either hasn't responded at all to the agents, and when I say hasn't responded, I mean even looking beyond that period where you can develop unconventional response, or people who progress at multiple sites while they're on treatment. Those are the truly resistant patients. The other way to do it is to come up front with anti-PD-1 alone. Some people don't believe you need to give the ipilimumab, and certainly ipilimumab may not be adding in every patient. Do a combination and look for a much higher signal than you would expect with single agent anti-PD-1. The problem, though, is that the melanoma is a relatively rare disease, and the current therapies are very active. So one of the challenges we have in our field is that if you're going to use survival as an endpoint, and you have survival rates at 2 years that are in the 60% range, or maybe higher, the studies are going to be enormous, and will require a large number of patients. So we may, even though I don't agree with this strategy, because I think we may lose some very active drugs, we may end up prioritizing drugs that have activity in the truly refractory, treatment refractory patients. Treatment refractory meaning patients who have had nivolumab, pembrolizumab, or the combination of ipi-nivo and have not responded, and then respond to some agent in the second line setting. So this is single agent anti-PD-1 versus ipilimumab and nivolumab. We use a number of criteria. Obviously, we look at the patient overall, but there are certain subgroups that appear to do better with a combination of ipilimumab and nivolumab. Patients who have high LDH, patients with BRAF mutations, interestingly enough, patients that are PD-L1 negative. So those are, and if you have a patient that has higher bulk of disease, you need a more rapid response, maybe you would use a combination. In our practice, probably because we have so much experience with a combination, we've had such good experience with a combination, that we tend to use a combination in most of our patients. The ones where we will use anti-PD-1 alone would be people who we don't think can tolerate any toxicity, and those perhaps, and also have, for example, very high level, they're PD-L1 positive. And those patients we might say, okay, well, risk-benefit ratio favors just giving anti-PD-1 first, and if they don't respond, then we'll give them ipilimumab and nivolumab subsequently. Oh, there are lots of unmet needs. Ocular melanoma doesn't respond very well. We've seen a few responses, but not many, to the combination of ipilimumab and nivolumab. Patients with mucosal melanomas or acral melanomas tend to have lower response rates. Patients who have high LDH certainly don't respond as well to these agents. And then, of course, all the patients who don't respond in the first place, who are essentially resistant to first-line treatment. In the BRAF/MEK world, so even if, for example, if you then go on after immune therapy and you have a BRAF mutation and you get a BRAF/MEK inhibitor, once those patients progress, we really don't have good strategies for restoring responsiveness. There are some trials going on, but not a huge number of trials. So patients who've progressed after immune therapy and after BRAF/MEK inhibitors, there's a huge unmet need. So despite all the success, unfortunately, we still have people in our practices that just don't respond to these agents and will unfortunately die of their disease unless we find effective therapies. One last thing I think I would mention is, although brain metastases are responsive to these agents, particularly for the immune therapies, the response rate in the brain appears to be similar to the response rate in the body. Still, lesions in the brain can cause substantial morbidity. And even though we can take care of them with gamma knife radiation, stereotactic radiation, they can respond to systemic therapies. If you have a lesion in the wrong place or you have a lot of post-treatment edema, you can have a lot of morbidity. So things to prevent brain metastases or treat them more effectively is still an unmet need in our field. I think that most of our trials now should include, instead of the way we used to do it, which is exclude patients with brain metastases, and this is an area that my partner, Dr. Kluger, has been working on a great deal, we probably should allow patients with at least small brain metastasis to be enrolled on our clinical studies. They shouldn't be excluded a priori from those trials. I mean, as we've seen for both BRAF/MEK inhibitors and for immune therapy, they seem to respond almost as well in the brain as they do in the body. For immune therapy as well, and for BRAF/MEK inhibitors, they respond, although perhaps the responses are not as durable. But we should not exclude those patients from trials in melanoma. I wouldn't exclude them for phase 2 studies, and I wouldn't exclude them from randomized phase 3 trials. As long as the disease in the brain is not causing symptoms or, for example, requires steroids. To be honest, there are so many studies out there and so many combinations. I actually don't know what's going to end up being positive. I think TIL modifications, I think, are interesting clinical trials, so more study on cell therapies is interesting. But all of these combinations, I hope a few of them will show enough activity that we can then move forward with another phase 3. But right at the moment, I wouldn't be able to predict which one. I'm certainly excited about the things that we're doing, and that includes cytokines and monocyte macrophage modulation, but there are lots of other, I think, very interesting approaches that are being done. Every institution has a different subset of clinical trials, and I think together as a field, hopefully we'll find something in the next 12 months.